Welcome, everyone. I have the pleasure of introducing Katie Brandt and Jennifer Pilcher today to talk with us about the obstacles families face looking for supports for their loved ones with FTD and tips and tools to be able to advocate for them. Katie Brandt is the Director of Caregiver Support Services and Public Relations in the FTD unit at Massachusetts General Hospital. Katie provides leadership for research, education, and community events aimed at supporting the caregiver experience for families impacted by Alzheimer's disease, FTD, and atypical young onset dementias. As co-chair of the National Alzheimer's Project Act Advisory Council on Alzheimer's Research, Care, and Services, Katie connects with experts in the field of Alzheimer's disease and related dementias and contributes to federal policy initiatives and research priorities that promote health equity and person-centered care at every stage of dementia. Katie is a passionate advocate in the rare disease community, inspired by her experience as a former FTD caregiver for her late husband. Jennifer Pilcher was awarded her doctoral degree in gerontology from the University of Massachusetts in Boston in 2005. Her professional experience has focused primarily on care and housing arrangements for elders with Alzheimer's disease and related dementias, including policy and fundraising work for the Alzheimer's Association of Eastern Massachusetts, the Alzheimer's Association of Utah, and the Massachusetts Association of Older Americans. In 2018, Dr. Pilcher founded Clear Guidance to return to her passion of working directly with clients and their families. Clear Guidance is a care management practice that specializes in working with clients and families challenged with atypical dementias, including FTD. Thank you, ladies, for joining us today.
Thank you, Esther, for that lovely introduction. Katie and I are so grateful to be here today to share some of the insights with you from the work we do together. As this is a workshop format, we welcome questions at any time. And we wanted to start by describing to you the image in front of you and why we chose it. So we chose the image on this slide because it represents the weaving together of different resources, which is a lot of what we're going to discuss today. Katie?
When I saw this cover slide, I said to Jennifer, oh, it's so perfect because it represents diversity. And I think in our community, when we're talking about diversity, we're also talking about neurodiversity, because it's not just Alzheimer's disease, but it's frontal temporal dementia, Lewy bodies, so many other conditions that our families are facing. So it's a great representation for us.
So I love this statement by Brene Brown, who's one of my favorite authors and speakers, who does a lot of qualitative research. She believes that we learn through telling stories, and I happen to agree, and I know so does Katie. As we go through the presentation today, Katie and I will both be telling you stories about people with FTD and their care partners that will help to illustrate the importance of what we're talking about together. We're going to start today with an overview of the universe of what is out there. You will learn as we go through the presentation that there are significant limitations of these resources for people with FTD, but it's important to have the foundation of understanding about what is available first. At this point, it's important for you to find the handout included in your packet that is entitled Home and Community-Based Supports for People with FTD. This is going to help guide our initial discussion and will be a resource to you going forward. The document outlines each support that is available at home or in the community, when this kind of support is appropriate, and the average cost of these supports. Please keep in mind that these costs are based on average costs on the East Coast. I think it's a pretty good representation of what we're looking at across the country, but bear in mind there may be some variation depending on where you live. There are 4 areas in which support for people with FTD can be performed. The first, of course, is at home. So we will go through what is available to you in that environment. The second is day and respite programs that provide support during the day and can be wrapped around or combined with home care. The last two are residential communities or nursing facilities that can provide support depending on the level of assistance you need. It's important to point out, none of these supports were designed for people with FTD. They were typically designed for older adults with Alzheimer's disease. Most of the people that work in these supportive environments do not have good training on FTD and how it should be different. That being said, we're going to walk you through what they are. First, we're going to walk through supports at home. In the home environment, there are three kinds of support available: hourly support, live-in support, and 24-hour awake support. Here I've used the term home health aide in this slide. It should be noted that there are other words that can be used to describe this person. Sometimes they're called certified nurses aides, sometimes they're called health aides or just aides, so you're not confused. We're going to go through this pretty quickly as you already have a handout that describes all of this. So I'm just going to give you a brief overview as we go through it, and then we'd love to have questions once we've gotten through most of it. So the chart you have in front of you details each of these kinds of care you can get in the home environment. I don't want to belabor the point, but I do want to point out a few things. If there's the name hourly in front of the kind of care, that indicates someone is able to come to your home intermittently. Most agencies have a 3 to 4 hour minimum they require. And the difference generally between a companion and a home health aide is that a home health aide can provide personal care, whereas a companion most often does not. A live-in person is appropriate if you have a separate bedroom they can use, and if the person with FTD doesn't have a lot of overnight wakefulness. 24-hour support is useful when a person with FTD does have a lot of overnight wakefulness and needs supervision both during the day and at night. There are some state programs through Medicaid that will cover a portion of this support at home if you are eligible. However, it's important to point out that there are age requirements for some of these programs that often make it hard for people with FTD to qualify, as they often are younger than age 65. You will hear me say a lot today, this a lot today about that not being a perfect fit. But with any of this type of care, it's essential you consult with an elder law attorney who can advise you what you might qualify for in your state. I did not prepare a slide on day programs because this kind of care is pretty straightforward, but in your packet, there is a description of day programs and when they're appropriate and the average cost. Next, we're going to discuss care in the community. The bottom line here is understanding the different levels of care and when each of them is needed. This slide represents the basic idea with an inverse funnel showing that the levels increase depending on the amount of assistance you will need, starting at the bottom with independent living and going to the top with long-term care in a nursing facility. First, we will discuss assisted living and what is available in this level of care. There are two levels, traditional and special care. So again, we've laid out for you here on the chart what these things look like. A lot of detail here, but the bottom line is that there are some distinct differences between traditional and special care. In traditional, you have intermittent support provided in the form of medication management, escorts to meals, daily activities and engagement programs, and scheduled help with personal care. In general, the care should not exceed 1.5 hours of support per day, but additional hours can be purchased. A special care unit includes all of what I've just described, plus provides a secure environment where a person with FTD can be supervised 24 hours a day. As well, they have more assistance with personal care, activities of daily life, and engagement programming that is specific to people with cognitive impairment. There are also some state-based Medicaid programs that can cover a portion of the cost of assisted living, and some states actually have what they call affordable programs or buildings. Again, you want to consult with an aging life care manager like myself or an elder law attorney, or both, preferably, to find out what kind of program you can qualify for.
It's probably even worthwhile to mention, Jennifer, that if you're a veteran, that there can also be supports through the VA. So I always encourage families, if you're a veteran, to consider working with them for supports. And sometimes you can be, pleasantly surprised what's available.
That's right. And elder law attorneys know about those programs that are available to veterans. There's a program called the Aid and Attendance Program, which is one that helps with home care or cost of assisted living. So that's definitely something to look into. Okay, the highest level of care that is available is called skilled nursing care. There are several reasons why a person might need to access support in a skilled nursing setting. First, and this is where it gets confusing, you might have a short-term stay in a skilled nursing facility if you had an injury or an illness or an exacerbation of a medical condition. This kind of stay in a nursing home is covered by your insurance or by Medicare. However, when you start to talk about long-term stays in nursing homes, so not short for rehab, but longer than that, there are generally two reasons why people choose this option. One is that the physical care of the person with FTD is too taxing for people at home or in assisted living. It could be that the person with FTDs has had a series of falls, requires more than one person to help them get around, or requires more supervision than can be done in other settings. Lastly, long-term care in a nursing facility is the only kind of care that is covered 100% by Medicaid if you are eligible. So I'll say that again because it's really important. This is the only kind of care that is covered 100% by Medicaid.
I think, Jennifer, we're really touching on an area of great anxiety for many of our families. We know that FTD hits at a younger age of onset, and so people are not planning for this type of 24/7 care. I often work with families who are struggling with very intense, a very intense symptom stage, or maybe they're even juggling working, parenting, and caregiving at the same time. So I just want to plant the seed that for any of the care options that we described today, to know that if you were to choose a care option, that is a choice that you make at a certain disease stage, or maybe during a period of intense symptom management, and that those decisions can always be looked at again at a future time. So I just encourage families, it's not that if you make the decision to go into assisted living or a skilled nursing facility, that is it for the rest of your journey. And sometimes that can be helpful for families who are struggling with the overwhelming financial future.
Yes, very important point. So one other thing I wanted to address here in terms of the challenges of some of this care. This isn't so much a challenge in long-term care, but certainly in assisted living and in home care. You will find that there's a lot of misinformation out there about FTD. And so you will find that some facilities actually have policies that they don't take people with FTD. And this is based on the belief that all people with FTD have behaviors that are too difficult for staff in assisted living to manage. And I would say there are even some skilled nursing facilities that have this attitude. So as we'll talk about in the second part of our presentation, it's up to all of us, care partners, people with FTD, and all of us advocates out there to educate the community about the fact that that is not always the case. And even if it is, that it's manageable in these environments. The other challenge that we have is sometimes there are certain buildings or communities that have age restrictions because of the way that it's zoned by the town or the state. And so sometimes you'll run into that as a challenge when you're looking at placement, that they simply can't move there because of the zoning. So just some things for you to be aware of when you're looking at this type of care.
Jennifer, we had a question that I think would be relevant to address now, because we were just talking about costs and what programs might cover this type of care. So the question was, can we explain the difference between Medicare and Medicaid?
Yes, I can. It's
yes.
a common, very common thing that people are confused about. So let me think about the best way to do this. So Medicare is a federal program. You are entitled to it either when you turn 65 or if you are a disabled person. So, and if you're a disabled person with FTD, what you need to know is if you're younger than 65, you should get on Medicare because it's very good insurance, but you have to be receiving disability payments for 2 years before you can enroll in Medicare. So that's an important thing. If you are thinking about applying for disability and you haven't done it yet, do it. Do it quickly, because that will get you that much closer to Medicare. So Medicare is health insurance, but it also will cover short-term stays in skilled nursing or having therapy like PT and OT and speech and things like that in your home. So that's basically what Medicare is. Medicaid is a state program. So each state designs their own Medicaid program. So in Massachusetts, our Medicaid program is called Mass Health. It's called a different thing in every state. Every state decides how to fund it, what they will pay for. And so there's Medicaid that pays for health insurance, and there's Medicaid that pays for long-term care. And then there are a few Medicaid programs that will pay for home care and assisted living. So it's important, because this is so confusing, it's really important that you see an elder law attorney that can advise you whether Medicaid long-term care is something you can access in the short term or in the long term, and whether you need to do planning for that, and whether any of these other community Medicaid programs can supplement the cost of assisted living or home care.
Maybe the big thing to think about too is that Medicaid has a means test. So they look at your income, your earnings, your assets.
Right.
I've had many families say to me, oh, we can't get that because we make too much money. And I would really encourage everyone to speak to an elder law attorney in the state where they're seeking care to assess their unique situation, because there's a lot of misinformation.
Yeah.
You need to speak with a professional, not your neighbor or, your friend at the local coffee shop. So I would just really encourage that. And I think to know that when you mentioned applying for disability, just so everyone's clear, you were talking about Social Security disability.
Yes. Yes. SSDI, usually called. Do we have any other questions before we move on, Katie?
I think there's an important one asking us to explain, is memory care the same as assisted living?
So I'll just flip back in slides just for a second. Whoops, that was it. So memory care is synonymous with what I'm calling here special care unit. Okay, I don't like to use memory care because it accentuates the fact that it's all about people whose major problem is memory. And the truth of the matter is there are people living in these units that have all kinds of cognitive impairment, not just Alzheimer's disease, which is the one that primarily leads with memory issues, right? So assisted living is there's traditional and then there's this special care. Memory care can exist in assisted living, but you also can have a memory care unit in a skilled nursing facility. So you want to make sure when you're looking at these programs that you understand whether this is a memory care inside of an assisted living or a memory care inside of a skilled nursing. These terms are used so interchangeably that it's not always clear, but in general, more often memory care occurs in assisted living.
I think the hallmarks, are that there's 24-hour staffing. It's probably a secure environment
Right.
in a memory care or special care. So those are some of the things you can look for. We had one last question about resources. Are there any resources for protecting college money set aside for school-age children from a Medicaid spend down in light of early onset FTD?
Yeah, I mean, that is a fantastic question. I don't have the answer. I think it is, though. That's my gut, is that yes, it is, because there are a lot of things that are protected like that. So that would really surprise me if it wasn't. But what I would say is call an elder law attorney. And if you need one, there is an organization called NALA. Yes.
Yes.
The National Elder Law Association. I was just making sure I said it right. So
I think it's National Association Elder Law Attorneys, and maybe Esther will look it up for us, and she'll confirm it.
Right. So you should go on their website and search for someone in your area, because they will know all of those rules about Medicaid, what's allowed, what's not allowed, what's going to be counted, what isn't going to be counted. So very important to do that, especially if you have money set aside for college.
Yep.
All right. Well, should we charge ahead here, Katie?
I think we should.
All right. All right. So no matter what kind of a resource or support you're going to use, whether it's in the home environment or in the community, there are a few very important approaches to introducing supports. I work a lot with families who report to me that they can't understand why the person with FTD is resisting having someone outside the family providing support or moving from home. When I question them about their approach, they most often say, "Well, I told him he needed to accept it." I wonder why that wasn't very successful. So this kind of approach is what I like to call the bowling ball approach, which very rarely works. Rather, we need to think about how to make this kind of transition more attractive. There needs to be a reason for the change that makes sense to everyone. The support you choose should be providing meaningful activity and interaction, not just supervision. We need to create things for caregivers and persons with FTD to do together that has purpose and is helping others rather than being the one helped. Katie, I think you have a good story to share with us as an example here.
Yes, we had a wonderful caregiver who thought about how her husband had such a strong work ethic, and he had had previous experience helping people with disabilities get jobs. So after his diagnosis, when he wasn't unable to work, she said to him, "They're looking for volunteers at the senior center. And there's another volunteer who's going to be driving by who said he could pick you up and you could go together." So that volunteer was actually a hired companion from a home health agency who picked up her loved one, and they went and worked together at the local senior center. And it was a way for her husband to have a safe afternoon and for her to have respite. But more than that, Her husband did have things to contribute. He was wonderfully social. He built relationships with the people at the senior center. He was strong and able-bodied, so he was able to help move furniture for lunch or the afternoon activities. And it gave him a sense of purpose, and he was contributing, but he needed the structure of that companion to help him. And it made him feel good that they were going together rather than he was being taken by someone. So it was all about the presentation. Yeah.
Yeah. Such a great story, Katie. And I know you and I have worked on many efforts just like that over the years. The second thing to know is that transitions take time. When I'm working with a client, I tell them to expect at least 12 weeks of a transition. If it's shorter, we celebrate. But if it's that long or even longer, we don't panic. You want to try to anticipate and plan as much as you can, but also plan for unforeseen speed bumps. As I say to my clients, put on your seatbelt and prepare for a ride. Always start slowly if it's possible to do it. Don't introduce a caregiver who will come 8 hours a day, 7 days a week. Start with a few hours, build rapport and familiarity. I wanted to tell you a story about a client that I worked with several years ago and his wife who had FTD. And she was a very conscientious care partner. She spent a lot of time with the assisted living before he moved. And we had all kinds of conversations about the behaviors that he was having, teaching the staff about what these behaviors were and what were the best tricks to deal with these behaviors. And hours of both of our time preparing for this move. And he moved and they handled the behaviors just beautifully. What we hadn't anticipated was shortly after his move, he started to have difficulty with his continence. We didn't know to prepare for that. That was a really unforeseen speed bump, which of course also was in relation to personal care and behavior around personal care. So it was a challenge. But because we talked about the unforeseen speed bumps, we were ready and we dealt with it. And I think that's part of where that's really important to have in your mind when you're making these transitions. Katie, I think you also wanted to add that this may be a good place to talk with your medical provider about the symptoms that you're seeing.
Exactly. And, when you're thinking about planning ahead, so caregivers always ask me, they say, how do I know what's going to come next? And what we know is that if you've met one person with FTD, you've met one person living with FTD. And so working with your expert medical provider, your expert team, they can look at how you or your loved one are experiencing this diagnosis, this condition. And so that you can make plans that are specific to you, not specific to things that you might read on the internet. So I think that that's just really important to talk with your medical provider.
I get a lot of questions in my practice about when is the right time to introduce a support or make a move. The way I like to think about these decisions is in the context of risk and how much risk you're currently taking. As I'm sure all of you appreciate, navigating the balance between independence and risk is a big challenge. We always want to err on the side of giving the person with FTD as much independence as we possibly can. However, it is essential that you are doing a constant and consistent evaluation of how much risk you have. How do you do this? How do you evaluate how much risk you have? There are some professionals you can engage in that will help you assess this. First of all, an occupational therapist can do a safety evaluation of your home to make sure you're mitigating the risk in your home as much as possible. This should be covered by your insurance. You can hire a care manager or a social worker like me to assess your situation and give you an objective opinion about how much risk you're taking.
Just think about the activity of going for a walk by yourself. And so you might think, okay, the things that I need to think about for this activity are, is my loved one steady on their feet? Do they know how to get home? But the reality is context matters. So if they love to go for a walk at 5 o'clock every day, and it's summertime when there's a lot of light at that time, or it's the fall when it's already pitch dark at 5 o'clock, that's a different risk assessment. Is it negative 10 degrees or is it 100 degrees out? That could also impact their safety. So it's really this constant evolving practice of assessment for risk. And again, it's a really great opportunity to involve your expert medical provider.
Absolutely. The last way that I like to think about risk is I like to try and imagine down here on the bottom of this slide, I've given you sort of a visual. I'd like to imagine there's a line between risky and dangerous. And I like to talk with my families about where they lie on that spectrum and how much risk they feel they're taking. And to try and introduce these supports as you get closer to the line of dangerous, but you haven't yet crossed over. And this is the way, this is really key to preventing crisis situations, which is the next slide. The best way I know to evaluate risk and to know when the timing is right is to be on the lookout for what I call red flags. We've given you some examples here on this slide of what those red flags might look like. It's also very important in FTD to anticipate and watch for visuospatial issues and or motor or gait issues, as this is a common risk factor that can lead to a crisis situation and a loss of independence. You want to adopt the support when you see these red flags, but before you think you need to, in order to avoid a crisis situation.
I think a lot of times we're just always thinking about the symptoms or what's happening with the person with the diagnosis. But actually, how the care partner is feeling can also be a red flag. So as the care partner, are you starting to feel resentful about your role as a care partner? Are you experiencing chronic health conditions due to high levels of anxiety or stress? Are you not able to fulfill your other responsibilities, such as working or parenting? And so considering those things as well, when you're thinking about what do you need to provide the best care plan and environment for your loved one? And also, I love to think about the transfer of skills. So sometimes I'll meet with caregivers that tell me a long, elaborate story about how their loved one cannot use a kitchen appliance. Like, they almost caused a fire in the microwave, or they can't use a toaster anymore. But then they'll tell me that they're still driving. We need to think about when you start to see challenges in one area, to assume that those challenges are going to be a crossover. So it's time to start putting in those extra supports and safeguards in place, especially for issues like driving and financial management.
The biggest challenge for any provider is lack of understanding of symptoms or behaviors. It is important for you to partner with your provider and to share what you've learned about your partner with FTD and learn together about the strategies that work. You may have to teach the provider at the same time that you're learning yourself. You will have to be specific about how Alzheimer's disease is different than FTD. It's important to emphasize that memory is not the primary issue. Rather, behaviors like impulsivity or being irrational or being socially inappropriate or having language issues, these are more often the issues that these folks are facing. And we need to be able to explain that to the providers.
So a great action step that everyone can take is when you're working with any outside provider, this could range from your primary care physician to your adult day health program. you have the opportunity to connect them with the AFTD program called Partners in FTD Care. This is an amazing network of healthcare providers across the country who are caring for individuals with FTD. They have a beautiful quarterly e-newsletter developed by medical professionals for medical professionals. And it's just a great way to connect healthcare providers who've had experience caring for FTD with maybe a healthcare provider who this is a new experience for them. Because that's what we really want, people to talk to each other and learn.
So you might be saying to yourself, well, okay, how do I learn about my partner with FTD? How do I know what to say to these providers? So I'm going to give you a few tools in wrapping up this presentation that I think might be helpful to you as a care partner. The most important thing is that you start with curiosity. Start with wanting to understand the behaviors or the symptoms that the person with FTD is experiencing. Rather than assuming what is causing the behavior or feeling frustrated by it, you'll need to adopt an approach of being curious, asking meaningful questions that will lead to discovery. In order to do that, you have to clearly identify the problem that you're seeing in as much detail as possible. Think about what was happening at the time when the behavior occurred. What were you doing? What was the person with FTD doing? So this is a list of meaningful questions that I encourage our families to ask when they're in a situation. What is the history? What is the background of this person? What need are they trying to fill? What could they be feeling? And so on. One of my favorite stories in working with a client who had FTD was I got called by an assisted living facility who said, we've got a big problem. One of our residents is putting on dirty medical gloves from the trash and walking around with them, and we don't know how to stop this behavior. And I said, okay, let me come in and we'll do a consultation. So I came in and I saw what was going on, and I said to them, well, are you aware that this woman used to be an OR nurse? That was her job. And they said, no, I had no idea. So I think she sees gloves and she knows what to do with them, so she puts them on. And by the way, couldn't we have a simple fix like putting a top on a trash can so that she can't get to the dirty gloves? So we worked through that. But also what happened was a discussion about, okay, this is something that's meaningful to her. How do we turn it from being a behavior into being something that's productive and meaningful to her? She also liked to clean the bathrooms, and she was always trying to clean the bathrooms, and she would do it with toilet paper and all this other stuff. So what we did was we gave her a box of clean medical gloves and a spray bottle full of water and some towels, and she spent several hours of the day going from each of the community bathrooms in her assisted living and cleaning them. And she felt very accomplished. So that's just a story where you can look at something that looks like a behavior, but when considering who this person is and what need they might have or what expression they're making, rather than just seeing it as a behavior, is really important.
So important to acknowledge the personhood at every stage. And we know that sometimes for family members, this can be incredibly emotional to see how your loved one is changing. And that's where it can be really helpful to bring in a professional care provider, because they don't have that same emotional attachment. So you can provide the backstory and they can help execute the care plan.
Absolutely. So in addition to these questions, which are really important, this is a tool that we use in our practice that I really like. This is a tool that was originally designed, it's called the ABC chart. It was originally designed for kids with autism, but I find it to be incredibly helpful when trying to look at objectively a behavior and figure out what could be causing this? What could be the reason for this? So the A is antecedent, meaning what happened before. The B is for behavior, and the C is for consequence, right? So what happened before the behavior, what was the behavior, and then what happened after the behavior. Really important to look at the date and the time of day that this was happening, in addition to what was the activity that led up to this. And what you will find is that this gives you some objective data that you can look at and share with your medical provider or your caregiver to say, here's what we've discovered. Also engaging your provider, whether they're a home care agency, a home health aide, or an assisted living, to use this kind of a tool to gather information about what's happening can better inform everyone involved and help inform how you might address that behavior and solve it for the person that's experiencing it.
There's an important thing to think about here. So we have a question that says, if a person has behavior issues such as aggression or another type of issue that causes them to be asked to leave a facility, what alternative do you have? And I would just maybe back that up a second and point to this tool as an effective tool and communication strategy to press the pause button on asking someone to leave. I had an experience where I got a phone call on a Friday afternoon from a director saying, we've got to ship this person out to a hospital. They're being aggressive. We're able to trace the behavior back to she loved her watch and the battery had stopped working, and she was desperate to push people out of the way to find more batteries. Once her favorite aide realized what was happening, the issue stopped. But we had to do some investigation to find out where was the aggression coming from, and then there was no need to leave.
Right. I have a similar story about an assisted living where I had a person with FTD who was in their 50s living with a bunch of folks in their 80s and 90s with various kinds of dementia, right? And I got a call saying, we have to send her out. She's pushing the other residents. And I said, well, let me come do an observation. So I go, and it turns out that this behavior was happening around mealtime, and the resident's room was down one end of the hallway, and the dining room was down the other end of the hallway. And the way they did it was they would go from the dining room and they would go to each bedroom and remind people that it was time to eat. And since hers was the furthest away, she was the last one to be cued to come to the meal. She would come out of her room and know where the dining room was and need to get there fast because she was hungry. And there were a bunch of 80 and 90-year-olds in her way. So remarkably, we moved her room next to the dining room and the behavior disappeared. So it's looking at these things in context. And Katie's absolutely right that when you first see that red flag, when you first see that behavior, that's when it's time to get in there with this kind of a tool and get working on it so that you don't get that message from the provider that they have to go somewhere else. And if you do end up in that situation, call an advocate like me. Because they're the ones that can help you, number one, try to work it out with the facility, work on the behavior, figure it out, or number two, figure out what your other steps are. So,
and don't forget to use this tool for positive outcomes too.
Right.
If your loved one has an amazing shower or personal care day, figure out what was different about that day that made it so good.
Right.
It's a learning tool on both ends.
Absolutely. So, the last thing I want to share with you is I love data. I'm a PhD, so I think that's part of where it comes from in my brain. But when, sometimes there are other things that could be contributing to behavior as well that are, biomedical issues that we need to be looking at. Not just what are the events that are occurring, but what else could be going on in this person's system. And we know that people with FTD are very sensitive to changes that go on in their body, and it can change their cognition or their behavior depending on how they're feeling. So I've given you some examples of some other charts that I like to use in working with home care agencies and working with assisted livings and in working with adult day programs. Let's look at, is there an issue with voiding? Is there an issue with, is this person going to the bathroom a lot? Could we be looking at a UTI or some kind of a minor infection that's causing this behavior? What does their bowel program look like? Let's track that. The one in the middle is a sleep chart. Let's look at whether on days when sleep is really disrupted, is that affecting behavior? Then you can take that sleep chart back to your neurologist or your psychiatrist and say, here's what I charted. And you can talk about whether it makes sense to do something different around sleep or not, right? But that's really where the power comes in these charts, is you as a caregiver have the data, and even if you don't feel confident interpreting it yourself, you can bring it to somebody who does, and they can help you with it.
And Jennifer, as you're mentioning these resources, I've just got a reminder to alert all of our listeners that we can, you can find resources at the bottom of the video under the presentation tab titled Presenters and Resources.
Great. Yeah, so here we are. And I want to leave you with this thought. The key reason to using tracking mechanisms is that it allows you to look at data from an objective point of view. A very talented woman I used to work with calls this getting in the balcony, which is the reason for this picture. Because you as a care partner are part of the dance or the show that is going on the stage on a daily basis, it's very hard to be objective. You need to picture yourself as getting in the balcony and looking down on the situation without any preconceived ideas. This can be difficult, but these tools we presented to you today will help you get there. So thank you so much for having us. And I know Katie and I feel very fortunate to be here and share with you some of these strategies today.
Thank you.
Thank you so much, Jennifer and Katie, for all of this valuable information. I am so glad that this resource is going to be archived on our website, and we are going to be able to share it for years to come with our families.